with that, we'll go on to the second talk of the day actually. And as I have told you earlier, a prolific VR surgeon and cataract surgeon, Dr. PRASHANT BAWANKULE, he'll be talking to us on the tips and tricks, how he does the cataract surgeries in this era of 3D. Over to you, sir.
Okay, thank you, Naresh, for getting me into your IC, this particular IC. Yes, the 3D digital assisted surgery for us is day in, day out. It's more than 4 years with more than, I should say 20,000 plus cases done already on this system, and which has established the role, at least in our ORs, as an integral part rather. It's by choice. If I have 2 theaters, most of the complicated cases happen in a 3D digitally assisted case. So is it just fashionable to operate like this or to look at the screen? Let us see through my presentation what are the exact advantages which Dr. Piyush has already spoken about, the advantages of this system, and we'll try to analyze how clinically it helps us out. So the basic thing, 2 or 3 things which a magnification or a viewing system should give you is a magnification, depth and field of view. And this system provides you a magnification which is 24 to 40% more than what an highest magnification of a microscope can offer you. Now look at this particular video where I am doing. This is all anti-segment because I have been asked to speak on anti-segment, so I will be speaking all these things. This is a high magnification video which I am operating on a 3D system. This is a posterior polar cataract. Look at the volume big. So anything which you see big, you can pick out the smallest of the things, and if you can see the smallest of the things, the predictability and the chances of iatrogenic damage to the adjacent tissues is less. So you can see the comfort, the magnification. This is, yes, on your microscope also you can operate at a very high magnification, but remember, there the depth and the field of view gets compromised, and therefore you have to balance between magnification versus the depth. So that is what here it is not compromised, and you can see actually the chunk of the material over here, actually the layers of the cortex you can peel, which are getting peeled off over here. So this is the magnification at high. Now coming to other thing, that is the depth of the field. It is 11 to 40% more than what a depth resolution and microscope offers. So in spite of high magnification, this is what it happens. Now you look, I am doing a nucleotomy. You can actually see the stratas of the nucleus. Unlike a microscope where you can see, but there you see in the sizes in the inches, whereas when you are operating here, you are seeing it in the, more than inches. So actually you can see the depth of the nucleus, you can appreciate, you can actually see how deep you have gone into the nucleus. And you can, and if you appreciate a depth with such a great intensity, I think naturally the chances of posterior capsular tear and all this I will be showing you through the one of the cases where I am doing an phaco in a case where the anterior chamber depth is less than 2 millimeter. So this is another case. Now look at this particular video. Look at the daring of a VR surgeon or an anterior segment surgeon, the ease with which his IA manual goes behind the epinucleus. You can imagine the difference between the epinuclear plate and the posterior capsule is hardly in millimeters. And see the confidence with which I could enter there and remove that and flip it off. Other place where the depth is very important is when you are doing a handshake technique during a scleral fixation. The area just behind the posterior capsule is not so well visible with the microscope, neither with the posterior viewing system, and this is where you already, here it scores much more here. Now look at the field of view. Why do you need a field of view, especially in complicated cases? See, routine cataract surgery is probably a routine field of view would do, but if you have a field of view as big as this, 3 to 5 times, especially when you are doing after cataract, I am going to do an iris repair job here. So cataract you can appreciate. For while doing an iris repair here, it's a case of a traumatic coloboma or thing. So you need not only intraocular tissues to be seen well, but you also want the periphery where you are putting your needle, proline suture, the needle simultaneously. You are doing multiple things, and so you really need a bigger field of view, which is possible with this system, and that is the real advantage when you are operating a complicated PDR, where you get a complete panoramic view of the whole pathoanatomy of the disease per se. So you can see the iris repair being done, And these are the process steps, especially when you really would appreciate the use of this. Now regarding the color filters, now look at this particular thing. I have stained, but it is not adequately stained. So I'm not able to get the proper view of the capsule in spite of staining. Now what I do is I use a filter over here, and see now suddenly after the use of a filter, the visibility of the capsule has suddenly increased. Now, this particular system, as Dr. Naresh Babu said, was initially launched for the use of vitreoretinal surgeon. But one such a costly elephant in one of your OTs blocking the anterior segment work would not do. So we started exploring the potential of this system into the anterior segment, and this was the study which we published in IGO 2 years back, which showed that the anatomical and physiological results are similar in both the groups of microscope versus 3D system. In regards to safety, 3D surgery is as safe. Surgical time, yes, only during the learning curve, and timeline and learning struggle, naturally with any new technology, is during the learning phase. But everyone appreciated the field of view, depth of perception, and a color contrast, which is quite superior to a microscope. So this was the publication which we gave to the world in July 2021. Now let us see through some of the complicated extreme cataract cases. Now this is a siderotic cataract. The whole, you can see the whole cornea is studded with the precipitate. So here the visibility of the posterior while doing cataract, doing a capsulorhexis is very pathetic. But in spite of this, you can see the comfort with which I could complete the whole procedure through the hazy cornea. So when you have a hazy cornea, use of certain filters, adjustment of the things will help you in getting over the visibility, and you can manage. And then the foreign body removal was done. Now this is another extreme case of a cataract nigra. Even such cataract nigra we can manage in this case with as much as comfort over here. So here you don't get a glow, just use of a proper filter will allow you visualization, and then you can see the use of under 3D we are doing a cataract surgery, and you can see the successful completion with installation of thing. Now this is a good case. This is a case of nanophthalmos with albinism with nystagmus with grade 4 cataract. Anterior chamber depth was almost 2 millimeter. So we really had a previous night, I had a sleepless night, how would I manage in such a shallow chamber? Would I have a Descemet strip, or would I have a posterior capsular tear, or the other complications which we anticipate in a case of a nanophthalmos? Well, here you can see the actual depth of the anterior chamber, which is only 2 millimeters. Because of sheer magnification, this 2 millimeter appears to be in inches. And so naturally you can further titrate the intraocular movement of your instruments, and thereby prevent the heterogeneity. And you can see the completion of a case and then putting of lens. Another second eye of the same patient, where we are using now the filter, because in a albinotic eye the red color becomes more prominent, and therefore you have to use filter to make it more palatable to your eyes. And you can see the again an anterior chamber depth of 2 millimeter, needing a lens power of 35 diopter, and without any iatrogenic complication we could have a successful completion. Now this is a case of grade 5 cataract with a capsular fibrosis. Another case, complicated case so called. We do a capsular CCC, and after that a routine cataract surgery was done, and it can be easily managed. Now this is a case of a phaco in a neovascular glaucoma. Here we have a vascular membrane, the iris has rubeosis, cornea was edematous. So after scraping of the epithelium, we are trying to just do a synochialysis, viscosynochialysis. After synochialysis, you can see I am putting an iris hooks, and once I put an iris hook and get a visibility, the rest of the steps, in spite of a bad media, that is hazy cornea, bleeding iris, we could complete it successfully and then follow it up with a AGV. This is another case, extreme case of a 280-degree subluxation where we planned phaco with CTR, and you can see I am doing a phaco. Here, such complicated combined surgeries, because of the sheer combination of field of view and everything, you can manage it. And you see that after doing a phaconucleotomy, I am removing the epinucleus, cortex, and then a CTR was put over here. Okay, and you see the capsular bag, you have to be very slow and think. And after now the CTR is being put, again if you have a good field of view, all these steps appear so easy otherwise for even for a novice surgeons. Now the thing is, this is a case of a trifocal, even premium IOLs we do, I would just run through this. Now this is another important case of a cataract with a iris repair. You can see that the iris is lost from here to here. So I am planning to do a phaco with a iris repair, and such a complicated case. So after completion of a phaco emulsification, you see that yeah, I will just come to it. After having completed the phaco, the iris is being hooked on, and then I am creating a scleral pockets to anchor the iris and bring it over here and trying to create a pupillary area. So one suture taken with such a big field of view, all these complicated steps of having a simultaneous view of the antechamber as well as the field of peripheral field as sharper as that is possible. Now I am hooking over here, the second suture goes here, and sorry, this mode. So I think I will just show the conclusion of this part of the case, and you can see I could construct a pupil over here. At the conclusion, we had a good pupil, so the patient would naturally have less chances of dysphotopsia and glare and all those things. Now this is another case with a cataract with a combined RD. So if you have to combine a cataract, it is easy to switch from anterior segment to posterior segment, and it's matter of less than a second to switch on. So after completing cataract, we are doing a proliferative diabetic vitrectomy for diabetic. This is again, now we are using certain filters, and you can see the panoramic view which you get. It's all encompassing, so you can actually see the multiple attachments of a membrane and all, and so the dissection becomes more easier, and it is less traumatizing to the surgeon as a patient. So this is cataract with. So to summarize, 3D digital surgery is here to stay even for anterior segment procedures because of the sheer magnification in unique combination with enhanced depth and increased peripheral acuity. And all this you can do at a low illumination, say 1/10 of the illumination, so less chances of phototoxicity and all. Color and light mapping are the other byproducts of this system which gives you additional advantages. So better you see, better you will perform is the dictum, and so naturally when we moved from loops to microscope, the success rate of the surgery cropped up, and now with this Ingenuity, the success and the predictability would be more so. So thank you, friends. And importantly, I would just like to make an announcement. We have actually, you saw all these videos in 2D. At 1:30 in Hall A, we are having a 3D show actually, where we will be showing you with the goggles actual 3D surgeries, videos recorded, because in that hall, that particular show, they are getting those special projectors. So please do attend, then you will understand what I am talking, because most of the videos which we are showing during our ICs are in 2D for you to understand what exactly it means. So it is something like in a theater, you will be watching the 3D with the goggles. So please do come and join us at 1:30 at Hall A. Thank you. Thank you, Naresh, once more for this.
Thank you very much, sir. Actually, I've got a few questions for you, sir.
Please, please.
What percentage of your cases are now done with 3D in case of cataracts?
See, for me, we have 2 theaters in our OT. So if I have a list of 20, we just shuttle between the 2. One has a simple microscope, one has this. But whenever it comes to a complicated case, by choice, we try to post it in the sequence of our theater in the Ingenuity. As you could see, I could do even the most difficult. I didn't show you simple cases.
Yeah. The other question is, what about the learning curve for anti-segment?
For me, I think so. Initially, say about 50, 60 cases, that's it. And that too, it was more of a mental block rather than a physical limitation or a physical difficulties which we had. Regarding the thing which many anti-segment surgeons talk about is the lag which comes in their way. Probably I have done now more than, I should say, 7,000-8,000 phacos on this system. I don't appreciate. Probably I might be a slow surgeon. That's why I don't appreciate the lag. For a faster surgeon, it might be so.
Yeah. And third thing is, what do you think will be the future of 3D surgery? You think it will be moving towards 3D, or people will still be holding on to if the lesser costly platforms come?
No, naturally, the only thing probably I feel why it has still not popularized is the cost, which is prohibitive. But it is something like that, anything technology comes with a price. And once you overcome the barrier of the price, and it is something like that, till I bought a Mercedes, really did not know why people buy Mercedes, and I used to say, साले के पास पैसा ज़्यादा है इसलिए करता है. But once I sit on the wheels of a Mercedes, I know what I was missing it. So unless you sit on this technology and appreciate for yourself after the learning curve, what happens most of the times, this company people get you for demo, and during that learning phase, if you try to get the understand the benefits of the system, you hardly appreciate it. So once you get over your mind block, then you start looking at the beauty which the system is offering.
Yeah, it's very addicting. And if at all any complications encountered because of the system, not because of surgery, I'm asking. So what are all the complications or the difficulties you encounter when you're using the anti-segment?
See, for me, in 4 years, we had only 2 times when the screen went off, and there was some software problem, and then we had to move to the second theater and all. So it was only 2 instances in 4 years with about 15-20,000 cases. So I think that even happens with our routine microscopes.
Yeah.
Or any systems, because all of us, all ophthalmic procedures are dependent on machines.
No, that is a technical aspect. While doing the surgery, do you find any procedure which will be difficult when you're doing? As such, no.
To vouch for, frankly speaking, I have never moved from Ingenuity. I am having difficulty in operating on an Ingenuity, so I had to move and get an eyepieces back into the system. Never.
Yeah.
Not a single case.
That's a very important point which you have made, because it's the mental block which prevents most of us from moving to. Thank you once again, sir.
Thank you, sir.
That was a wonderful presentation. And next, yeah, please.
Sir, myself an anterior segment surgeon, and if I would like to transition towards this procedure, is there any stepped approach, or do I do the surgery completely, or do I perform a few steps in the initial this thing, or can it be done simultaneously in both the
Yeah,
steps?
exactly. So the first foremost thing is to believe in self that I can do it. And second most, the only block which comes during the learning of this is the mental block. For me, when I started anti-segment cases, even the Alcon people were telling, don't use it, sir, we are not responsible, we are not responsible. But now I can vouch and tell with all these publications which are coming, that you do not need. Other thing which comes into our mind is that a laparotomy surgeon had a problem in converting into laparoscopic surgeon. This is what we have been hearing for so many years. Many of the laparotomy surgeons could not convert into a good laparoscopic surgeon. But remember why they could not convert. They are used to looking into the abdomen like this and operate. While we as an anti-segment surgeons or ophthalmic surgeons are otherwise also looking into a microscope, not directly into the tissue, but we are looking at a 45-degree here and then operating here. So our hand-eye coordination is always better. So it's a matter of few cases that you understand. Just here you are looking another 10-degree up. Here, while in a microscope, you are looking here and operating here. So we are used to indirect vision otherwise also. So the transition as such is not there. But initially you should start with basic cases where you can really, which do not stress you out otherwise for surgery, so that you start appreciating. And once you know that, then you can go for extreme cases like the ones which I showed.
Okay. Thank you, sir.
Thank you.